Hello everyone, my name is Noor and today I'm going to show you a sample presentation of a clinical hospital case. This is MK and he's my patient. He's 29 years old, Indian male. His BMI is 19.3, lying within the normal range. And basically he works as a plumber. He's got no known allergies, no family history mentioned, and his lifestyle is fine. He doesn't smoke, doesn't drink, and isn't on a particular diet. He got admitted to the hospital on the 16th of October 2018. And before I tell you why, I would like to show you his physical examination sheet. Well, now I'm going to pinpoint the most important values in this slide, which is the oral temperature. It's 38 degrees Celsius, meaning he's got mild fever. His respiration rate is 22 breaths per minute, means he's got tachypnea, and his ECG shows some ischemic changes in the lateral leads. However, the most important characteristic point in this slide is the blood pressure. As you can see, it's 210 over 130, and this is not just hypertension, but a hypertensive crisis, which is a medical emergency. So what's the problem? The chief complaint, as we mentioned before, was fever and shortness of breath, as well as having a hypertensive crisis. And the primary diagnosis of the patient as he stayed in the hospital was as followed: hypertension, dyslipidemia, heart failure, as well as having pneumonia due to MRSA, which was community acquired. And the most surprising part of it is that the patient had no idea about what's going on. He didn't know he had any chronic condition, let alone having a pneumonia infection. Alright, let's speak about the current medication list now. And for that, we're going to have a lot of tables, so I'm not going to mention every single piece of information. You see, it's quite scary, but it really isn't. You can always pause the video and read the rest of the medications. I'm only going to mention a few of them that are extremely important. The red tabs here means that this is an emergency medication. Okay, so they gave him furosemide IV injection 40 mg for the relief of pulmonary edema resulting from the heart failure as well as hypertension, and nitroglycerin 10 micrograms for the treatment of hypertension and heart failure. And here we have labetalol 4 mg IV as being the drug of choice for treating hypertensive crisis. However, if you look here, you can see that it is not following the guidelines. The guidelines from what lexicon indicate that you should start with 2 mg per minute infusion, and they've given him 4 mg. So you can have that as an intervention or as a note to point out. The other medications that were given to the patient, we have here a dual antiplatelet therapy, aspirin 100 mg and clopidogrel 75 mg in order to prevent blood clots from happening. We have atorvastatin 40 mg, which is a high intensity dose, this one for the management of hyperlipidemia. And we have nifedipine 60 mg capsules for the management of hypertension. We have clarithromycin 500 mg oral tab for the pneumonia, and multivitamins to maintain the normal metabolic functions and to compensate for any lost electrolytes. Now we go to the lab data of the patient, and the first one would be the vital signs. Now here I would like to ask myself one major question. Did we resolve the chief complaint? What was the chief complaint? Mild fever and hypertensive crisis. So we look at the temperature and blood pressure. As you can see, they were high a couple of 2 days, and then they started to resolve. The fever went down, meaning that the infection was resolving, and the blood pressure also went down, meaning that the patient was responding to the therapy. General biochemistry, here we speak about the kidney, serum creatinine clearance, of course, calculated from Crocroft and Gault equation, and the blood urea nitrogen. As you can see, the readings are a bit disturbed, indicating mild renal impairment in the first couple of days, but then it was later corrected. The CBC of the patient is fine. As you can see, we have no reds, no blues. Everything is within the normal range, indicating no anemia, no hemorrhage whatsoever. So we're just going to skip it. The liver function, well, you can see that the bilirubin and the albumin, we have disturbed data indicating liver dysfunction. It could be due to the diseases that he's having or due to the medication use. And the albumin, we have hypoalbuminemia, and I want you to keep that in mind when we come to the calcium, because it's going to affect the concentrations of the calcium. Now, the lipid profile. We mentioned before that the patient had hyperlipidemia. We didn't specify what kind of hyperlipidemia does he have. Does he have mixed dyslipidemia? Does he have hypertriglyceridemia? Does he have hypercholesterolemia? If you look at the lab data of the lipid profile, you will see that only the LDL is increased, consequently affecting the total cholesterol numbers. However, the HDL and triglycerides are fine, meaning that his primary diagnosis is that he has hypercholesterolemia. Okay, now we come to the electrolytes. We have the calcium. This is the normal range, and these are his serum calcium concentration levels. As you can see, he has severe hypocalcemia. But again, we can't judge, we just need to look at the albumin. He has hypoalbuminemia, which means that we cannot depend on the serum calcium. We need to calculate the corrected calcium. And for the first box, the corrected calcium would be 2.8, and the second box is 3.2, which is still severe hypocalcemia, so the management plan would still be the same. Now, how exactly do we do the corrected calcium concentration? Basically, the corrected calcium equals serum calcium plus 0.8 multiplied by 4 minus the serum albumin. Okay? The potassium levels here are also an issue. He's got hypokalemia in some of the days. That's why we gave him KCl supplements, potassium chloride. Now we go to the maintenance or home medications, and we supply him with medications for 1 month until the next refill, where we can see how the patient is doing and check on his progress. As you can see here, we have a list of 7 medications. We have aspirin and clopidogrel. The dual antiplatelet therapy is still there, and basically they are to be taken as 1 tablet after food, and the most common side effect that we should warn the patient about is bleeding. Atenolol as a beta blocker is given twice daily, and we should tell the patient that it might take time before the drug starts to work, and you shouldn't stop beta blockers abruptly. That's very important. We also gave him another medication for hypertension, which is nifedipine, calcium channel blocker, and it's important to tell the patient to avoid grapefruit and grapefruit juice because they interact with the medication. We also have atorvastatin, the high intensity 40 milligrams, 1 tablet after dinner at night. We have the multivitamins, oral tablet to be taken in the morning or the afternoon, because if the patient takes it at night, he might be hyper energized and maybe he wouldn't be able to sleep. And we have omeprazole 20 milligram oral tablet to be taken half an hour before breakfast. Now we go to the assessment sheet of the drug interactions. We have a bunch of interactions within the drugs that the patient was taking. Most of them are of category D, and one of them is of category X, meaning that this is a contraindication and these 2 drugs should not be taken together. Now, the category X interaction happened between ipratropium and potassium chloride. Now, ipratropium, I didn't mention this before, but the patient was taking it for the shortness of breath resulting from the heart failure and the hypertension, and the potassium chloride supplement for the management of hypokalemia. Now, what happens if we take them together? Ipratropium is an anticholinergic agent. It enhances the ulcerogenic effect of the potassium chloride, even when it's given in the nasal formulation. So we should avoid the combination. The other interaction is with clarithromycin. As we can see, it interacts with both atorvastatin and nifedipine. And as being a macrolide enzyme inhibitor, it increases the concentration of both of these drugs, possibly leading to toxicity. So we should consider the therapy modifications. We also have an interaction between clopidogrel and omeprazole, because omeprazole may diminish the antiplatelet effect of clopidogrel, and again, we need to consider the therapy modification. And now we come to the final part of our presentation, which is the pharmacist care plan. We have several interventions that we could change, but the most important one, in my opinion, is the last one. The calcium levels are dangerously low, and so the intervention would be to give the patient 0.5 milligram per kg per hour, IV infusion over 4 hours. The other interventions that we can have is that we can change the drug atenolol. Well, basically, atenolol is a beta blocker that works for the management of hypertension, but since the patient also has heart failure, we can give him a more suitable beta blocker. For instance, carvedilol that works for both hypertension and heart failure. We can start with 3.125 milligram twice daily. Then if the patient was unresponsive, we can always increase it to 6.25 milligram twice daily. Now, we go to the drug interactions. If you remember, we have a category X interaction between ipratropium and potassium chloride, so we shouldn't mix them up together, and we can change the ipratropium to salmeterol, which is a beta-2 receptor agonist with a strong bronchodilator effect, achieving the same mission as the ipratropium. Of course, we have another drug interaction with clarithromycin. As we said, it's an enzyme inhibitor. However, macrolides are upon the preferred agents for treating pneumonia, so we're not going to change it. We're only going to monitor for the other medications in case of having toxicity. And these are the references for the data interpretation as well as guidelines for the correct therapy use for the management of conditions. I hope you had a beneficial time listening to this lecture. I know I didn't mention every single detail about this patient case, however, I wrote them down so you can always pause the video and take a look at them. And thank you very much for your kind listening.